All right. Well, hello and welcome everyone. It looks like it is 1:45 Central Time, so we can get started. Welcome everyone to Breakout Session 1A, Improving Patient Care and Reducing Health Disparities Through Cultural Competence. Just a few things as you're entering the room. Thanks again, everyone, for joining us. Just note this session's being recorded. If you have any technical difficulties, please just utilize the chat feature and task and Steven will try to help you out. This is a very full presentation with a lot of content, but if we encourage you to still use the chat box for questions and interactions, and we'll try to get to those either at the end or outside of the session. And then, yeah, just feel free to use that chat box at any time. So just to get us started with the presentation, learning objectives for this presentation. So at the conclusion of this session, participants will be able to explain the creation, process, and funding for the initial phase of the St. Charles Madras program, identify use of cultural competence as a building block for measurably improving patient satisfaction and care, and develop and collect measures on cultural competence. So at this time, it's my great pleasure to introduce our two speakers for this session, Rebecca Dobert. Rebecca is a program manager at the Oregon Office of Rural Health. She administers grant activities and provides technical assistance to rural health facilities and EMS providers across Oregon. A former health policy legislative staffer, she has worked significantly as a certified nurse assistant and volunteer EMT in rural frontier communities. She holds a BA in American History and certifications as a rural health clinic professional and volunteer victim advocate. She serves on the advisory council of the Oregon Office of Disability and Health, volunteers for the Sexual Assault Resource Center, and has participated in advocacy for type 1 diabetes for over 20 years. Other speaker is Canga Picar. Candy is the CNO at the St. Charles Madras Hospital. She attained her BSN in Cebu, Philippines, and immigrated to the United States in 1991. She earned an MBA through the University of Phoenix and doctorate nurse practitioner through Cabela University. She has board certifications in ANC, a nurse executive advanced specialty, and fellow of the American College of Healthcare Executives. Candy won the California Nursing Excellence Award for Leadership in 2009. In 2019, she received the Transformational Pioneer Award in Nursing Leadership given by the Northwest Organization of Nurse Executive. She's a frequent speaker on nursing, patient satisfaction, employee engagement, and leadership. Candy is passionate about transcultural care, diversity, inclusion, and equity. It is Candy's desire to spread the transcultural care project to all other healthcare systems, providing care to a diverse population. Again, Rebecca, Candy, thank you so much for being here, and I'll turn it over to you.
Thanks, Andy. Hi, everyone. This is Rebecca from the Oregon Office of Rural Health, and I am thrilled to be here presenting to you with Candy today. I want to take a quick moment and recognize our colleague, Soleil Berry, who is our HRSA Small Rural Hospital Improvement Program Officer and who worked with us on this project and presentation, but can't be here today. And I'm very proud to present Soleil's portion of the work today. So the presentation showcases the work of Candy and her team at St. Charles Madras to improve patient experience by focusing on culturally competent care. We're going to start by taking a few minutes to set the stage. We're going to take a few minutes to just set the stage about these evidence-based interventions that connect culture and language and the improvements in health outcomes. So how is cultural competence relevant to rural? 60 million Americans live in rural communities, and the demographics there are changing. While this group knows that rural is not a monolith, it's important to show the numbers related to that increasing diversity and help adjust some of the misconceptions about it. One of those misconceptions is that rural America is the white agricultural heartland. The truth is that the face of rural and small town America has evolved, and the racial and ethnic diversity of rural communities has increased in the last decade. People of color represent more than 1 in 5 rural residents and are 83% of current population growth. Rural Native American Indians, Asian, and Latinx groups are growing the fastest, followed by African American populations. Another misconception is that rural America is primarily farming communities. And while the agriculture sector does account for a larger share of employment in non-metro counties, in fact, the largest employers in rural are education, healthcare, and social assistance. Changing demographics can lead to unmet healthcare needs, and rural, racial, and ethnic minority populations can face additional challenges in terms of access to care. This presents an important opportunity for policymakers and providers to decrease disparities in health and healthcare access. This slide, here we have some data related to the American Indian and Alaska Native populations in the US, which is the focus population of the St. Charles Madras project. There are an estimated 5.2 million American Indians and Alaska Natives in the United States, and 54% of that population lives in rural areas. 68% of those rural dwellers are living on or near their tribal homelands. American Indian and Alaska Native populations have faced long-term social, economic, and political inequalities due to colonization, forced migration, land loss, and cultural devastation. American Indian and Alaska Native people continue to die at higher rates than non-Native populations. For American Indian and Alaska Native people, life expectancy is 5.5 years less currently than the national non-Native population average. That lower life expectancy and disproportionate disease burden is a result of discrimination in the delivery of health services and cultural differences. The St. Charles Project showcases their community's efforts to address those disparities. Quickly want to highlight our main source of resources. The Federal Office of Rural Health Policy, FORP, has coordinated activities related to rural healthcare within the U.S. Department of Health and Human Services for over 30 years. And we all know that rural areas have unique opportunities and challenges that aren't always addressed in other research and grant programs. So FORP is really the voice for those rural communities in HHS. And while FORP works across all health issues, their programming includes a focus on health equity. Building around the issue of geographic equity, FORP has increased efforts to capture data and inform programming around the dual disparities facing rural, racial, and ethnic minority populations. The activities we're discussing in the presentation today were initially in part funded through the Small Rural Hospital Improvement Program, or SHIP, and many SHIP priorities align with the required and optional activities for Program Area 1 of the Medicare Rural Hospital Flexibility, or FLEX grant. SHIP supports small rural hospitals of 49 beds or fewer, and this is inclusive of the FLEX grant's targeted critical access hospital population. Both SHIP and FLEX resources act as a catalyst to help these rural hospitals meet components of value-based care, including quality improvement. Candy will discuss the St. Charles Madras Hospital HCAHPS patient experience related project in detail, but as she does, keep in mind the myriad ways in which her original SHIP goals are in alignment with FLEX grant core MB-QIP measures for patient engagement. Also note that most of the ripple effect and ongoing continued work related to the initial project is also applicable and supportive of core and additional or optional MB-QIP measures. So the SHIP and FLEX programs for Oregon are administered by the Oregon Office of Rural Health. Like many SOARs, our work is to offer technical assistance and resource opportunities to rural hospitals, RHCs, and EMS agencies. This slide shows a bit of what rural means in Oregon. Oregon is 98,000 square miles, so that's larger than the area of the United Kingdom. We share border with 4 states, and also our entire western border is made up of the Pacific Ocean. With all that area, our total population is small, with a total head count of about 4.2 million people, 33% of whom live in rural designated areas and 2% in frontier. Frontier means 6 or fewer people per square mile, and 10 of our 36 counties are frontier designated, and they're shown on this map here in dark green. You can see it's a large swath of territory. All of this is to say that Oregon's SHIP and FLEX eligible hospitals serve a huge and incredible range of landscapes and terrain and the communities within them. And those can be both barriers and resources for our providers. This next map shows the location of Oregon's 32 SHIP eligible hospitals. Of those, 25 are critical access, all of whom also participate in our FLEX programming. You can see they're in every region of the state, although not every county has a hospital. St. Charles Madras is right smack dab in the middle of Oregon, the only hospital in 1,781 square mile Jefferson County, and it's entirely surrounded by other rural and frontier designated counties. Oregon's SHIP work has increasingly focused on value-based purchasing. In fiscal year 20, 90% of our SHIP awardees chose to work under VBP. And within the VBP program area, HCAPS targeted activities are very high value, with 60% of our awardees completing HCAPS projects reporting measurably improved scores for their targeted subjects. Again, these HCAPS targeted improvement projects are in alignment with the FLEX program's MBQuip priorities, enabling states to support this work both under SHIP and FLEX. And I can't think of a better illustration than the St. Charles Madras Cultural Competence Project that shows how identifying and addressing these care gaps using metrics like patient satisfaction scores lead to truly meaningful and impactful benefits to patients. And with that, I'll turn you over to Candy here about the project itself.
Thank you so much, Rebecca. I am just so excited to share about our project in Madras, Oregon. So St. Charles Madras Hospital is a critical access hospital with 25 licensed beds, and our services range from surgical, imaging, family birthing center, emergency care, and outpatient. And for the purposes of this study, we targeted our population basically on the Native American Indian patients. The Native American Indians comprise 30.1% of all our inpatients in the critical access hospital. And our hospital serves a county that is composed of a diverse community group, 19% Native American Indians, over 40% Latinx, and the rest is everybody else. And that's about an estimated population of over 23,000 people. Now, for our project, our initial rollout period was in 2018. Next slide. So we had a huge problem that we were trying to solve. We failed to provide culturally appropriate care. And how did we know this? Well, we have nurses and physicians sharing their negative experiences and actually really difficult challenges in dealing with the diverse ethnic groups. And we're also hearing stories from our patients stating that they felt disrespected and they felt uncomfortable being in our hospital. And finally, as a leadership team, we really had a deep concern for lack of cultural competency. Now, furthermore, we looked at the data. And our data showed that for our Press Ganey patient satisfaction, we definitely had a suboptimal participation of our Native American Indian patients. For example, 78 patients only responded to our survey. And then out of those non-white respondents, only 8 were Native American Indian patients. And you can see that our HCAP stop box scores ranked us at the 13th and 14th percentile. Next slide. So we wanted to determine what the impact was of cultural competent care to patient experience. We also wanted to ensure that we provide our frontline staff with an understanding of our Native American Indian culture. And the third thing is we did not realize that as a hospital, we were not in compliance with CLAS. And CLAS stands for the National Standards for Culturally and Linguistically Appropriate Services. And finally, we wanted to adhere to the Joint Commission requirements of cultural care. The photo to your right is just an example of the cultural summit that we held. And the funding, as I've indicated, was actually given to us through Rebecca's SHIP grant funding, the Office of Rural Health. And I'm excited to share with you about how successful it went. Next slide. So we then looked at Native American Indians as our target inpatient who were discharged from our hospital, and then asking ourselves, we need to look at implementing evidence-based, culturally competent care and compare that with our previous practice of non-cultural care for patients. And we looked at 120 days as our pilot study. And the foundation of our evidence-based care was on Leninger's culture care theory of diversity and universality. So what that means is that in every culture, there is something universal, like we have a need to be loved or to love. And the diversity piece of that is how we express love or how we receive love. And we also recognize that there was already an established guideline produced by Douglas et al. In 2014. So the question was, how do we translate these guidelines into practice? Now, the photo to your right is actually a photo of our Patient Family Advisory Council, composed of our Native American Indian tribal leaders and members of our Indian Health Services Clinic. Next slide. Many people ask me, what are the three components of the Transcultural Care Project? So for those of you who are really interested in replicating this project, I can tell you that there are three components to that. The first one is establishing a Patient Family Advisory Council. The second one is providing cultural training and education. And the third one, which is a bigger, more complicated component, is how do you, as an organization, establish a culturally competent facility? So the first one for PFAC, or Patient Family Advisory Council, we asked our council to review and update policies and procedures to reflect cultural care from birth, illness. Am I still here? I felt like I lost the connection.
We can hear you.
Okay. Birth, illness, and death. And then also, how do they provide cultural competency and training to our staff? And then finally is reviewing the hospital signage, artifacts in order to reflect cultural care. Now, in regards to staff training and education, we held a conference in transcultural care and invited the world-renowned speaker and theorist, Dr. Campina Bacot, who is the founder of transcultural care. And together we implemented the IAPCCR questionnaire and tested our pilot caregivers. And finally, how did we establish a competent organization? We created a specific job description to have a liaison to our tribal communities. We also revised all nursing job description throughout the whole healthcare system, because we are part of a health system, and required all nurses to have cultural competency as an essential duty of an RN. And we also held monthly conference call with the Indian Health Services Clinic to review and evaluate Native American Indian cases who were patients from our hospital in terms of what worked well and what did not. Next slide, please. This is an example of the cultural considerations policy that our Patient Family Advisory Council wrote. I'm so proud of them. Our tribal leaders from different tribes, Warm Springs, Wasco, and Paiute, worked together with our frontline nurses and wrote this policy from the ground up, from birth, admission, illness, surgery, and death. And I have to tell you, this has been an eye-opener for us because we realize that we have not been truly considering the culture and life ways of our Native American Indian patients prior to our project. And Tammy Wilson, who is one of our nurse managers, is now our liaison to the Warm Springs tribe. Next slide. And I'm excited to also share with all of you that we added some artifacts that reflect the Native American Indian culture in our healing garden. So salmon is a symbol of life and abundance for our Native American Indian patients. And then the photo to your right is the legendary priestess, she who watches, and it's a really important figure, spiritual figure, for our Native American Indians who believe in the Great Spirit as part of their healing process. Next slide. I wanted to share this slide because there's a story behind this. So 7 years ago, our leadership team wanted to reflect the culture of our communities. So we commissioned a local artist and created this large metal artwork at our main entrance. While in 2018, when we had our Patient Family Advisory Council look at them, the tribal leaders were really offended because the photos that were featured belong to the Navajo tribe and not our local tribes. So after we listened to them, we called the artist again and worked with our PFAC, and the photo to your right is the new rendition of the metal artwork. So moral lesson of the story, we need to listen to the voice of our community members. Next slide. Now that I've given you all those soft parts of our project, let's go to hard data. For those of you who are excited about numbers, Table 3 is a comparison of our Press Ganey inpatient satisfaction survey participation based on racial demographics in 3 years from 2016, 17, 18. And without going through the details, it just shows you that NAI for our Native American Indian population, we have a very low participation. And to your right, Table 4 is the comparison of the Press Ganey satisfaction survey results based on HCAP stop box scores. Again, for the past 3 years, we really ranked between 12 to 30th percentile in rate the hospital and recommend the hospital. Next slide. Now we listened to our PFAC. Our tribal leaders said to us, why are you continuously sending mail only mode to our Native American Indian patients? Apparently, we were informed by the tribal leaders that the Native American Indian patients are of an oral tradition. They do not respond well to written documents. So immediately, our leadership team decided to switch to phone-only mode, and we've seen from 2018 to current an increase in the participation. This is not the latest data, but we sure can provide a continuous increase in our patient satisfaction survey participation and scores. Next slide, please. So if you look at the results from 2018 to 2020, for example, in rate the hospital, look at the increase, 67.74 71.76 to 73.68 as an example. And according to Press Haney, it only takes about a few points that makes it significant. So by us switching to phone only mode, we've also asked Press Haney to calibrate those results based on the mode of survey. Now, the data to your right, we recognize that an increase in our patient satisfaction scores also meant a decrease in the number of patient grievances. So for example, when we started the project in 2018, we have 59 grievances, and in 2020, we're down to 13. And that is continuously going down for 2021. Next slide, please. And other serendipitous results here is that the CPT1 deficiency, I don't know if you're familiar with that. We found out that our Native American Indian children have a genetic disease called CPT1 deficiency. And in collaboration with our information technology and our physicians, we were able to create a treatment protocol specific for these children. And we would create an alert notification in Epic. So when they would show up to our facility, we can immediately start the treatment protocol. Because if we delay the care of these children, it will result to severe harm. And in September of 2020, we were actually recognized by Epic for using technology in the treatment of these children. And then we're also excited to share the tribal leaders appointment to our Patient Safety and Quality Board Committee. So St. Charles is a system. We are over 100 years old. And for the first time in history, we have an ethnic minority being a member of our board committee. That's definitely a win. And then, just an added bonus without thinking about it, just receiving that Transformational Nurse Leader Awards was an added bonus to this. Next slide, please. So the limitations of our study is that we have an unpredictable number of Native American Indian patients discharged from our unit. And we also have a limited number of original research studies that truly demonstrates the relationship between cultural competent care with that of patient satisfaction. But overall, the project was really critical in transforming the care experience and also our caregivers' awareness of cultural care. And number two, we are definitely promoting equity of care. And I'm not sure if I added in the slide here that over a month ago, we ranked number 3 in the nation as the most racially inclusive hospital throughout the United States. And this was given to us by the Loan Institute. Next slide, please. So we are barely scratching the surface. We're actually still in the process of making sure that we're sustaining our practice through policies and procedures. And we're also identifying other groups who need a voice at the table. For example, we started our Latinx Patient Family Advisory Council. And next month, we're launching our LGBTQ Patient Family Advisory Council. And our 30-year long-term project is workforce diversification. What that means is, to give you a context, right now, I only have one Native American Indian RN who is mixed race, and also one Latinx or Hispanic RN. When in fact, the community we're serving is over 40% Latinx and 30% Native American Indian. And together with Rebecca, we are in the process of replicating this project statewide and nationwide. wide. Next slide, please. So this is just a photo of my vibrant group, our Latinx Patient Family Advisory Council, and they were involved in the remodeling ideas of our family birthing center. Next slide. This is our Latinx art that showed or reflect the seven different countries that we serve. And I have to tell you a quick story in this. One of our Latinx members said, you know, I have been here in Madras for a long time, and this is the very first time that I feel valued, respected, and seen. And through the artwork that we have actually commissioned our artists to work on, they felt more seen and valued. Next slide. The fabric of life. So we asked our designer to weave in the Native American Indian culture and the Latinx culture and use these themes in remodeling our family birthing center. And we just finished the remodel. I forgot, I'm sorry I didn't bring the pictures here, but it has brought a lot of joy amongst our caregivers and our communities because they really feel that we value them and we see them. Next slide, please. So before I end my presentation, many people ask, how do we become culturally competent? Well, according to Competence, there are 5 constructs to becoming culturally competent. The first one is, so remember the mnemonic ASKED, A-S-K-E-D. A stand for awareness. Ask yourself the question, are you aware of your own biases or prejudice? Or do you have a presence of racism and other isms in your life or in your family? And as for skills, do you know how to perform cultural health assessments in a sensitive manner? K for knowledge. Do you have the knowledge of the genetic conditions present in the community that you're serving? Are you aware of all the different life ways and maybe values that are surrounding you and the people that you interact with? E for encounter. Are you intentionally creating an encounter with someone that has a different cultural values than you, or someone that looks different from you? Or are you running away from that encounter? And I can't blame you if you're running away from that encounter. Researchers Marcia and Lopez stated in their research that intercultural exchange is very complex and creates tension, especially if you don't understand the culture of the person that you are dealing with. That's why it's so important to learn about people's culture. And finally, D for desire. Ask yourself, do you have the desire to be culturally competent? Remember, without desire and without really asking yourself to be culturally humble, there can be no cultural competency. So I want to pause right now and ask you, as somebody who works in your company, in your facility, in your daily operations, who needs a voice at your table? Have you reached out to different groups of people that can help you operate your daily work, that can make you successful? Next slide, please. And we have a conference link here that is available for you to watch. We're so sorry we don't have enough time to play the link, but we did have a link available to all to watch this wonderful conference we held between our staff and Native American Indian clients. Next slide. And for more information, if you want to read health equity resources, these are available for you. You can click on the links and it will take you to the different topics. Remember, it takes all of us to study, to learn, to be humble, and learn from each other in order for us to reduce healthcare disparities and increase health equity. With that said, next slide. If you want to get a hold of us, these are our emails, and feel free to ask us some questions. Thank you so much. Rebecca?
Thank you, Candy. Yeah, and we do have a few minutes for questions. It looks like I think you can drop them in the chat box, or you can definitely feel free to email them to us, reach out at any time with any questions about the project. As Candy mentioned, we are working on replication and pilot projects for this based on just the great success that the hospital and health system has continued to have with the Native American Patient Family Advisory Council, and now the Latinx Patient Family Advisory Council. And there's just really been a lot of really great measurable success with the project. And as she mentioned, all of the serendipitous and ripple effect, updating the CPT-1 protocols in EPIC and the way that this is translated. Yeah, and I wish we can send out also with the presentation. I would encourage everyone, when you get the presentation link, do go in and follow the video link. You can watch both the full cultural competence conference on YouTube, and also the video link we included with the presentation is a very moving and important testimonial from that conference, from the tribal leaders in the community, talking about some of the historical traumas of the patient population that were and continue to be very important for their caregivers to understand when they're treating their patients. So we encourage everybody to watch that.
Rebecca, I think there's a question on SHIP funding. So for those who asked the question, where did we use the funds? So number one is the guest speaker services. And she did not only charge fees for speaking, but she was what I call my consultant in how we can operationalize this project. And then I also used her tools, which were also expensive, in doing a scientific assessment of the cultural competency of our staff before the conference and after the conference. And of course, we have other panelists. We also provided those fees from the SHIP grant. And those are the things I can remember, Rebecca. It has been a long time ago.
Yeah, well, and most specifically, and I'm sorry, I can't see the question. So just to address the use of the SHIP funds, the focus of the project was HCAHPS, was that those patient satisfaction surveys. And the way that the hospital went at improving those scores were primarily through that targeted education and training through the cultural competence conference. And then, as Candy mentioned, some very good pre and post training survey questions of the staff population, and then also the pre and post training for the patient satisfaction scores. So they implemented that training and education element for quality improvement for HCAHPS, and then also measuring those patient satisfaction scores after they implemented some of the other informational response that they got, for example, using not using a written component for a Native American population that is not happy to receive written requests from quasi-governmental organizations, quite frankly, and who have an oral tradition. So again, just to sum up, the evidence-based training for cultural competence with pre and post-training staff learning and understanding surveys, and then implementation of what they learned from the trainer and to improve those patient satisfaction improvement scores. So for care, and then all of those elements ended up being rolled out in the other ways, for example, in updating their EPIC triage modules to find the CPT1 deficiency in patients right at entry in the emergency department, to revise the nursing positions. So I said, take some very basic stuff, patient satisfaction, and the information they had to improve that. Extrapolating from that, you could find myriad ways to change policy, programming, staff interactions with them. So it can seem kind of boring, but when you drill down to the details of really what patient satisfaction means, it's good care, it's quality care, it's quality interactions, it's a quality environment. I think the artwork is really especially representative of that, hearing from the community that this was the first time they felt represented in these spaces. That's a quality environment. That's a different way to receive care. So I hope that answers the question clearly. We could talk about this for a long time.
Thank you so much all for joining us. This has been a fun experience for Rebecca and I.
Yes, thank you everyone for attending. We really appreciate it. And these slides will be made available. So if you have more questions, we can put you in contact with Candy and Rebecca. And then thank you, Candy, and thank you, Rebecca, for presenting. We're so thankful you were able to do that. Just a few housekeeping questions real quick. There will be a 15-minute break. And then we'll reconvene at 2:40 p.m. Central Time for a group discussion on the 2021 quality improvement projects. So I will post the